Hello everyone, my name is Dr. Bhatt and with me today is Dr. Kwan. Today we'll be continuing our series on applied anatomy. These videos will focus on the upper extremity anatomy and specific procedures that plastic and hand surgeons perform on a regular basis. So the first procedure that we're going to do right now is we're going to expose the extensor musculature of the forearm, and we'll extend that into the dorsal hand and wrist to eventually expose the carpal bones. Somebody has nicely and graciously cut the skin for me, so we'll elevate the skin away. Just like we talked about fasciotomies for the flexor region, sometimes we have to do fasciotomies for the extensor region, again, for similar mechanisms, such as fractures that cause hematoma, crush injuries, anything that causes an excess of swelling where the muscles are living in within this confined compartment and the swelling needs to be released. So in this example, I'm using a blade to cut through the muscular fascia, and this is exactly what we would do in the operating room. Maybe perhaps not with such a wide exposure, but we would just release the fascia overlying the muscle so the muscle and the vessels and the nerves have room to breathe in a situation where they're getting compressed. Sometimes we have patients who have something called necrotizing fasciitis or infectious fasciitis, and we actually have to debride everything we see, specifically the fascia, the deep and superficial fascia. Down here, you'll see these superficial veins that in the operating room we would usually clip. But today, I'm just going to cut across with wild abandon. You see this right here? This is the extensor retinaculum. So that maintains the wrist extensors in position. And it's what divides each separate extensor compartment. So this fascia has interceptations that goes down to bone in between the extensor compartments. I'm going to incise this retinaculum so I can show you that. So going back to the extensor anatomy, we cut this retinaculum, the extensor retinaculum, and now you can see clearly these tendons going up across the dorsum of the hand, across the metacarpals, into the fingers. These are your extensor digitorum communis extensors, because right now we're in the fourth extensor compartment. So you can see these tendons, when I pull on them, if this was a live person, that would pull the middle finger back. And same thing, this would pull the index finger back. Now you can see that there's actually one other little guy going to the index finger. So here's the EDC to the index finger, but you see this other small little tendon right here. I'll show it to you a little bit more clearly in a second. See how there's a muscle belly that's a little bit further down the forearm, more distal. This is your extensor indicis proprius to the index finger, because your index finger has 2 tendons, and so does your small finger, whereas the rest of the other fingers only have 1 tendon per finger. So if this goes to the middle, this is the EDC tendon, or extensor digitorum communis, to the ring. And see this tiny little guy? That's the one to your small finger. And these all live within that fourth extensor compartment. Here you can see both extensor tendons coming in to the sagittal band right around the MCP joint. So we harvest the EIP, the extensor indicis proprius, a lot of times for thumb reconstruction. If somebody has a ruptured or attritional rupture of their extensor pollicis longus, we'll harvest this tendon at the level of the MCP joint, and we'll transfer it to the end of the extensor pollicis longus. Okay, so EDC to the index finger, EDC to the middle finger, EDC to the ring finger, and then EDC to the small finger. So that's all within your fourth extensor compartment. So you can imagine a laceration right here would cut across quite a bit. And then coming proximally, if we can, we'll see if we can find the terminal end of the posterior interosseous nerve. See this little yellow stringy guy? That's your posterior interosseous nerve. You can take this and use this as a graft, or you can just cut it back in the cases of patients with pain in their wrist capsule. So a lot of times if I'm going in to do a salvage procedure on someone's wrist, I'll actually just remove that nerve to decrease their pain because it just goes to the wrist capsule. And that's at the base of the fourth extensor compartment. We were talking about the fourth extensor compartment underneath this retinaculum. We talked about the extensor indus proprius tendon, which also lives within the fourth extensor compartment, along with the extensor digitorum communis. What I'd like to show you right here is actually the radial sensory nerve. You can see how there's multiple branches. So if somebody lacerated the radial side of their wrist, they could cut across these. And these guys actually, we'll repair them. Sometimes we won't repair them. We'll actually bury them because when these develop scar balls in the end of the nerve, they're called neuromas, they can be really painful in the radial sensory nerve. It's just a very finicky nerve. Okay, so then coming back to our extensor anatomy, I'd like to show you, so you see the septums that they're real. There's these interosseous septums between the retinaculum and the bone, and that separates each of those extensor compartments. So you see there's a tendon over here. This is in the next extensor compartment. So I'm going to cut this septation here. This is, again, going down to bone. And lo and behold, because we're moving radially, this is the third extensor compartment. So you see this tendon right here. This is your extensor pollicis longus tendon, which extends your thumb tip and inserts into the distal phalanx of the thumb dorsally and extends the tip. And that crosses, right in this region, it crosses your second extensor compartment. So I'm going to free this up just a little bit more just so we can see the anatomy. And this is important because we often have patients with lacerations in this area, and we have to figure out which tendon which tendon is which. And if you know your anatomy, it makes things a lot easier. Again, going to the radial side, extending the thumb, okay? And this next fascial extensor compartment is the second extensor compartment. And I know that based on where the extensor pollicis longus is, and also because of this, again, a separation, this septum that goes down to bone. And I can also see where those tendons are inserting. So it tells me exactly where I am. You see how there's two tendons right here? These are your wrist extensors, the extensor carpi radialis longus and the extensor carpi radialis, extensor carpi radialis brevis, extensor carpi radialis longus right here. And they insert into the base of the third and second extensor metacarpals, respectively. Okay? And these guys will extend the wrist. Moving more radially, so we've gone through the fourth, the third, and the second extensor compartment. So next is going to be your first extensor compartment, and that's where your abductor pollicis longus and your extensor pollicis brevis live. And again, I can go through the septum, or alternatively, I can just incise the fascia over the first extensor compartment. This is actually a common surgical technique called the de Quervain's release. De Quervain's release, patients can develop swelling and pain around the extensor tendons within this area, and then that causes narrowing and swelling within the tendinous fascia, this extensor compartment. And then that in turn causes the self-propagating cycle of swelling and pain around those tendons. And so patients often come in complaining of radial-sided wrist pain, especially with thumb abduction. It's very common in mothers who have young babies who have to lift their babies quite a bit, very common in females. So a lot of times we'll treat them initially with splinting or steroid injections, and if that fails, then we'll do a surgical release. And when we do the surgical release, we incise this fascia right over the extensor, the first extensor compartment, and just release it. You can see this defined, this very clearly defined fascia right here. Okay, and then you have your first extensor compartment tendons, your abductor pollicis longus, which goes to the inserts of the radial first metacarpal base, and then your extensor pollicis brevis, which inserts in the base of the proximal phalanx of the thumb. So that's your first extensor compartment. And now we can go back to the ulnar side of the wrist. So this is the next extensor compartment, which is the fifth extensor compartment. And you can see this tiny little tendon right here is your extensor digiti minimi. Okay, and that lives within that fifth extensor compartment. And then the last and final compartment is your sixth extensor compartment. And here's your ECU tendon, your extensor carpi ulnaris tendon, which inserts in the base of the fifth metacarpal and extends your wrist on the ulnar aspect. So just in review, it's all relevant surgical anatomy because it's not uncommon that these get lacerated, or alternatively, like we talked about with the de Quervain's release, you actually have to just release over the tendons. Okay, so extensor carpi ulnaris in the sixth extensor compartment, extensor digiti minimi in the fifth extensor compartment, the EDC tendons and the EIP, extensor interosseous proprius, in the fourth extensor compartment, the extensor pollicis longus in the third extensor compartment, the extensor carpi radialis brevis and longus in the second, and then our de Quervain's release first extensor compartment right here. The first extensor compartment also intersects or overlaps the second, about 9 centimeters proximally, and that can be a source of pain in patients. That's called intersection syndrome, and that occurs right here. A lot of times we treat that conservatively with steroid injections, but occasionally you have to go in and surgically release it, but you can see that crossing. That's very different than the extensor pollicis longus, which crosses more distally. So moving on, so we talked about the extensor anatomy, we talked about the extensor retinaculum, we talked about intersection syndrome, we talked about de Quervain's tenosynovitis. Now we can look at the actual wrist capsule and bones themselves. So I often will go either over the third extensor compartment, the EPL, or I'll go at the fourth extensor compartment to get access to my wrist. Good. So we're retracting these tendons. I'm feeling this bone spur on the back of the distal radius called Lisser's tubercle. Just distal to Lisser's tubercle is the radiocarpal joint, which is where the radius meets the scaphoid. So now I'm going to take a 10. I'm going to take a blade, and I'm going to do a very wide flap, wide exposure here. This is not what I would always do in the operating room, but this way you get a better sense of the anatomy here. But there's a thick, fibrous, a thick capsule here that's a very discrete and real capsule. I don't know if you can see these transverse fibers, but they're actually oblique fibers that are called your extrinsic capsular ligaments. And that's what maintains the back of the carpal bones so that they don't slip backwards. And these connect the radius to those carpal bones. I just cut the second extensor compartments. Clearly, I wouldn't do that usually clinically. When I do a dorsal approach to the wrist, I maintain these capsular ligaments to repair them afterwards, but for the sake of anatomy, we're going to take them today. There's a ligament that connects your scaphoid and your lunate, and that's called the scapholunate ligament. It's an intrinsic connection to maintain the carpal relationship of these bones, so that every time you move your wrist, the bones move in a coordinated fashion. If I had the ability to pull traction on it, I'd be able to show you. So this is the scaphoid, proximal pole of the scaphoid. This is the lunate right here. And then this bone right here, curving around the ulnar side, is the triquetrum. So the mnemonic I learned when I was in medical school was some levers try positions that they can't handle. And that goes from proximal radial to distal ulnar. So scaphoid, lunate, triquetrum, some levers try positions. Pisiform is on the volar side of the triquetrum. Some levers try positions that they, so trapezium at the base of the first metacarpal, the trapezoid at the base of the first metacarpal and second metacarpal, that they can't capitate is right here, and handle hamate right under the base of the fourth and the fifth metacarpals. So the capitate's at the base of the middle metacarpal. And all of those bones can get fractured, or like the trapezium, it can develop arthritis between the thumb metacarpal and the trapezium, and that's a bone that we often take out for thumb CMC arthroplasties. An arthroplasty is basically creating a new joint. So thumb CMC or arthroplasty, which is also called a carpometacarpal arthroplasty, all we're doing is we're taking out the arthritic joint, which is at the base of the first metacarpal and the trapezium. So we're taking out the trapezium. And then a lot of times we're resuspending the first metacarpal. Not everybody resuspends it, but many people do. And you can do that a variety of ways. You can do that with a tendon, like the flexor carpi radialis that we reviewed earlier. You can do that with another tendon, like the adductor pollicis longus. You can see this bone that's starting to emerge right here. And she does have pretty significant arthritis here, so it's a little bit of a challenge to get into the joint, but we're getting there. Usually I wouldn't obviously disarticulate the first metacarpal, but this is not a traditional situation. But so do you see this joint? This is the base of the first metacarpal right here. Let me find that probe. And there's not much cartilage left here, and there's a lot of erosions. And then the same thing here. This is the trapezium, this saddle-shaped bone, and there's not much cartilage. And centrally, I think if we get this bone out, we'll see that it looks a little bit different. When I'm doing a thumb carpometacarpal arthroplasty, I'm taking this bone out. Usually it's through a small incision over here on the dorsal-radial aspect of the thumb, more radial than this. And you can imagine that my visualization of it's not very good, so I have to trust my anatomy that I'm in the right place. So I get around the bone with a blade. And you can do this arthroscopically too, with a really small camera scope, and like a small burr, just to shave down this joint. But with open arthroplasties, we actually take out the whole bone. So then we take something smaller than this. This is a rongeur. And we grab the bone and we kind of slowly rotate it out of its spot. So I would grab it with the tool like that and then just cut around the bone. It's very gruesome, this surgery, but it doesn't always look so inelegant. Okay, so here's our scaphoid, here's our distal radius, this is the base of the first metacarpal, and then this is the trapezoid. And we took out the trapezium bone, which is the source of the carpometacarpal arthritis, or basilar joint arthritis of the thumb. Most of the time we just take out the whole bone, and this is the bone kind of in pieces after we removed it. You can see the joint space. I mean, part of this was iatrogenic, that was me doing it, but there's dips and cavities in there, and like the cartilage is very eburnated. That's because she had a pretty bad arthritis at that joint. And a lot of times at this stage, we'll resuspend the first metacarpal to the second metacarpal, or we'll just resuspend it with a tendon like the abductor pollicis longus or the flexor carpi radialis. Here's the trapezoid. Here you can actually see a much better view of the volar side, the volar surface of the scaphoid. We had seen the proximal pole, and then this is a distal pole. So if somebody had a fracture of the distal pole, I would enter in more on the volar wrist as opposed to the dorsal wrist. If it's the midpoint or the waist of the scaphoid or the proximal pole of the scaphoid, then I would usually enter in dorsally through the approach that we took before. Other things that we could review just very quickly is the musculature of the hand, the intrinsic musculature of the hand. So these are those fine little motor muscles that allow you to do the fine motor actions of human beings with their fingers. So here's the first dorsal interosseous muscle, and you can see it's inserting on the base of the index finger, and this is what allows you to abduct your index finger. It's a very important muscle, and a lot of times we see this atrophy or kind of shrink if somebody has an ulnar nerve issue. On the other side of that is your adductor pollicis, which is more on the volar side, and your radial artery lives volar in between those two muscles, and so does your ulnar nerve branches. So this is your first dorsal interosseous, which abducts your index finger. And then this is your adductor pollicis, which adducts your thumb towards your index finger. This abducts your index finger away from the long finger towards the thumb. That's the first dorsal interosseous. Your radial artery lives in this space after it comes around dorsally. We can look at the back of the hand. So the interossei are named such because they live between bones. So your first dorsal interosseous lives on the radial side of your index finger metacarpal. Your second dorsal interosseous lives between your second metacarpal and your third metacarpal. This is your second interosseous muscle. And then I'm going to keep on cutting across all these tendons. Here's your third dorsal interosseous right here, and that lives between your third metacarpal and your fourth metacarpal. And then your fourth dorsal interosseous lives between, it's right here, that lives between your fourth and your fifth metacarpals. Metacarpals are often fractured, and our exposure for an open reduction terminal fixation is similar. We would just make a dorsal incision through the skin, reflect those tendons, those extensor tendons in the way, and then expose the bone. For example, if we were going to plate a metacarpal. So here's the long finger or the middle finger metacarpal. There's 7 interossei. There's the 4 that are dorsal, and there are 3 that are volar that live on the volar side of these muscles. The abductors are the dorsal ones. So we say pad dab. So dorsal interossei abduct and palmar interossei adduct, pad dab. So we were talking about the dorsal muscular anatomy, the dorsal intrinsic muscular anatomy. Now I'll show you the volar aspect of the intrinsics, at least one of them. So you can see right here, you see these little vertical fibers. Those are actually connecting the skin to the underlying tissues. So I'm just going to go ahead and divide them. Right here you can see the median nerve branching into little digital nerves. I cut across some of them in my exposure, but this branch right here would be coming into the first web space and bifurcating into the ulnar side of the thumb and the digital nerve to the radial side of the index finger. I'm going to come across those nerve branches right here, and this is the one to the radial side of the thumb. I'm going to come across them just for exposure purposes, but these are often cut with lacerations and we repair them. Here's the FPL tendon right here, and then here's that adductor that we were talking about before, and here's those bifurcating nerves. See that? So here's the radial digital nerve to the index finger, and then the ulnar digital nerve to the thumb that are all coming from the median nerve. I'm going to cut across those. Okay. Here's your adductor pollicis that we saw on the other side, volar to the first dorsal interosseous, and this is the muscle that connects to the thumb first metacarpal. It originates at the third and the second metacarpals volarly, and it brings the thumb towards the index finger. It's very important for pinch. So there's another muscle right here that you're starting to see, and it's right adjacent to your tendon. Here's your flexor tendons that we dissected before. Here's your flexor digitorum superficialis. It's the more superficial tendon right here. And then you see this muscle belly that's on the radial side of this tendon right here. This is your flexor digitorum profundus to the index finger. And there's a muscle belly that's originating on the tendon. It's the only muscle belly that does that. And this will insert into your lateral bands for your extensor apparatus. It also inserts in the first metacarpal in the sagittal band structure. It'll help flex your metacarpophalangeal joints, and it'll help extend your IP joints, your interphalangeal joints. Here's that FDP to the index finger. Here's that lumbrical. Sorry, this is the FDS to the index finger. Here's the lumbrical to the index finger, which you have 4 lumbricals. They're all living on the radial aspects of the flexor digitorum profundus tendons to the index, long, ring, and small fingers. Okay, and we'll follow this around. So let's flip the hand radially, and you can see this tendinous structure right here. This is called your lateral band, and this is all these are all made from contributions from things like your lumbrical. Here's your lumbrical right here. And also your dorsal and volar interossei. On the radial side, the lumbrical contributes. On the ulnar side, only the interossei contribute. And this helps, you can see it comes into the PIP joint as well as the DIP joint, so it contributes to interphalangeal joint extension of the fingers. This transverse structure right here that's maintaining the position of the extensor tendons around the metacarpophalangeal joint, this is the sagittal band. These are important structures both for finger extension, but also because they can get damaged in other processes, or they can become imbalanced in other processes like rheumatoid arthritis. And that imbalance can cause things like swan neck deformity. Again, here's your first dorsal interosseous. Here's a tendinous slip that's going to your lateral band. And it's also connecting to the base of the proximal phalanx for abduction. So if you look at the back of the finger, we already skinned it. Here's your extrinsic extensors, your extensor indus proprius and your extensor digitorum communis coming underneath the sagittal band and creating this tendinous insertion on the base of the middle phalanx. That is your central slip. And then you have these lateral band structures that are coming from your intrinsic muscles, like your lumbrical and your interossei, and then just your interossei on this side. Your lateral band is right here. Right here. And those help contribute to PIP joint, proximal interphalangeal joint extension, but as well as they create the terminal extensor. And I can't extend her finger, but I don't know if you can see that a little bit better in the light. You see this tendon right here. This is a contribution from your lateral band on the ulnar side, and this is a contribution from your radial lateral band. And those come together and coalesce to form the terminal extensor for your distal interphalangeal joint. So the extensor mechanism of fingers is very complex.